and welcome to our Intro to Thermal Qst webinar. The webinar will be presented by Ofrit Bar-Bachar, the project manager of our clinical and scientific affairs here at Medoc. Before we start, a few housekeeping rules. First, don't feel lonely. We have other people attending this webinar, but we chose not to share the attendee list in order to keep people's privacy. You are all on mute, but you can ask your questions using the Q&A panel. Type in your questions and we will get to them at the end of the webinar. If you are having trouble with computer audio, please click the microphone icon on the left bottom navigation bar. The webinar is being recorded and we will send you a link to the recording a few days after the webinar. And last but not least, we would love to get your feedback on how we did. You will be redirected to a very short survey at the end of the presentation. Please fill it out if you can, so we will know how to make our next webinars even better.
Thank you very much, Gilad, for this introduction. I'm very happy to be here. So today's webinar's topic is Intro into Thermal Qst. We'll talk a little bit about what QST is and the types of QST that are around. Later, we'll touch upon the subject of static QST. And then we'll go a little bit deeper into dynamic QST, condition plane modulation, temporal summation, offset analgesia. And we'll try to understand what we can find out from the results of QST. I want to hear from you guys and get to know you a little bit better. So could you please fill in this poll so we can see how experienced you are in QST and what QST means in your life? I'll give it a few more seconds. Okay, let's stop the poll. Okay, so great. We have a very, very diverse crowd. A couple of you have, a quarter of you have used it in the past, and some of you are using it right now, and some of you are here to learn, and I'm very happy that you're here. Let's see if I can contribute to your QST knowledge. So QST, quantitative sensory testing, is a psychophysical testing method in which sensory stimulus is offered and a behavioral response is obtained. This is a subjective test, and that's why it depends very much on the patient's cooperation. In order to have good methodology, in order to get high repeatability, we need a very standardized stimulus and a very standardized environment. The reaction that we want to obtain from the patient needs to be known in advance and communicated to the patient. As we perform QST, we're testing the whole of the sensory nervous tract from the skin to the brain. And that's why it's very hard based on QST to pinpoint where a problem may be if we see a deficit. We always need to keep in mind that if we want to use QST in a clinical setting, we need to have a clinical picture and a good anamnesis. Let's go a little bit into static QST. When you speak of static QST, we speak of a simple test in terms of stimulus and reaction. In static QST, we usually try to say something about the function of the peripheral nervous system. There are different types of QST. For instance, there's the very well-known von Frey monofilaments or the pinprick in mechanical QST. Then there is electrical QST, vibratory QST, which is often done by using a tuning fork, or in this case, a computerized device like the VSA 3000. Then there is pressure algometry. You can use a manual pressure algometer, or you can use the computerized one like Medoc's Algomed. And then, of course, there's thermal QST, and this is mostly about the function of the small sensory nerve fibers that cannot easily be tested using EMG. In the picture, you see Medoc's TSA2. In thermal QST, this is about the function of these very small sensory nerve fibers. The thinly myelinated ones, the A delta ones that are transducing cold and first pain, and the non-myelinated, the C fibers, the very slow sensory nerve fibers that transduce warmth and second pain. When we talk about the types of threshold that we want to see in thermal QST, we have, for instance, a cessation threshold. This is the first temperature intensity at which the patient is able to sense a specific stimulus. There's a pain threshold. This is the first temperature intensity where the stimulus becomes painful. And then there is the pain tolerance threshold, and this is the highest or the lowest temperature intensity that the patient can tolerate. Of course, when we are talking about threshold, we need to compare a patient's results to other people's, their peers, normative data. Um, Normative data is a large amount of data that has been gathered with people that are known to be to have normal sensory nervous system, and in this way we can compare age and gender matched normal controls. Based on such comparisons, we can come to conclusions about the test results. When we talk about the sensation threshold, around the sensation threshold, we can see, for instance, hyperesthesia, a person who is more sensitive to a sensory stimulus than his peers. There's also hypoesthesia, a person who is less sensitive to a sensory stimulus than his peers. The allodynia is a phenomenon where a non-noxious stimulus is perceived as painful. This is usually tested with a paintbrush, for instance. The hyperalgesia is a person who has a lowered pain threshold, and hypoesthesia is a person who has a higher pain threshold as compared to their peers. When we want to test sensation and pain thresholds, we would like maybe to use the reaction time inclusive method of limits. Limits can be used in thermal testing, in vibratory testing, and in pressure pain threshold testing. A limits test, for instance, for warm sensation would start at a neutral temperature, an adaptation temperature of 32 degrees. 32 degrees feels a little bit like skin temperature. And as soon as you place the probe on the patient's skin, they will feel it first as a little bit warm. And after that, they get used to it. That's why it's called adaptation temperature. And then they will not feel it no longer. When we do a limits test, we have the temperature, in this case, rise at a very steady rate, for instance, 1 degree per second. This is quite a standardized rate, until the patient will press the button and thereby stop the rise of the temperature. The temperature will go back down to the baseline, and then the test will be repeated. If the patient will not press the button, the temperature will keep rising until 50 degrees, and that's where our software stops it from causing any harm. Usually we use several repetitions, at least 3, but you can also use more than 3 repetitions. Let's see how it looks like in our software. So in this case, you can see that the temperature drops. So this is a case of cold sensation. We start at 32 degrees. That's the green line. And here is the blue line, and that's the line that represents the normative data for the age and gender match controls of this person. And you can see that we did the test 3 times, but you can choose to do it more times in order to increase repeatability. The results at the end of the test are averaged and compared to normative data. Excuse me. The advantages of the limits test is that it's quite a fast test to do. There's quite some normative data that has been collected around the world, and it's one of the most used methods around the world. Additionally, it's very suitable for all types of thresholds, for instance, for cold detection, but also for cold pain threshold, and for warm detection and for heat pain threshold. On the other hand, because it's a reaction time inclusive test, it may not be very suitable for all types of populations. You can consider, for instance, that people that are elderly or have some kind of cognitive deficit may not respond in time and will not be, you will not be able to compare those results to normal controls. In this case, you may want to choose to use a reaction time exclusive method, for instance, the method of levels. And the method of levels can be done in thermal testing. Of course, von Frey is a method of levels, and electrical testing. The method of levels will look something like this. Of course, we start from a baseline temperature of 32 degrees, and then the temperature will climb and stay for a few seconds at a certain level. And then we'll ask the subject, did you feel a stimulus, yes or no? And let's say the subject felt a stimulus and they answer yes. Well, that's wonderful. Then the algorithm will look for a temperature that's between the baseline and the temperature that was felt, for instance, 33.5 degrees. And now we give this temperature. And then let's say we ask the patient, did you feel that, yes or no? And they say this time, no, I didn't feel that. Then the algorithm will look for a temperature that's between what we felt and what we didn't feel. And let's say this time they felt it. And you see that this way, the test is narrowing down. So at the end, the user can also determine the final step for this algorithm. The levels has advantages of very high precision. It's also suitable for all types of population. People that are that will do worse on a reaction time inclusive test will maybe do better in reaction time exclusive tests like levels. And there is some normative data that has been gathered. On the other hand, and disadvantage is that it's more time consuming. And it may be it's less suitable for pain thresholds because we don't want to sensitize an area by giving a super threshold stimulus. So the previous tests that we discussed, like cold detection, warm detection, heat pain, cold pain thresholds, are tests that are widely conducted around the world. And one of the leaders in QST is the German Herpetic Pain Network, the DFNS in German, who endeavor to investigate neuropathic pain of all kinds. And this group has a very specific protocol, and they have very standardized measures and instructions, and they have gathered much normative data and do a lot of research. You can see in section A of their protocol that they use cold detection, warm detection, TSL, thermal sensory alignment, and paradoxical heat sensation, which is an up and down temperature raise and drop. And they do cold pain threshold and heat pain threshold. After that, they have another few tests that are not done using thermal stimuli. We already mentioned normative data, and to use normative data, you need to know that normative data are very patient specific. We cannot compare a young lady of 22 to an elderly man of 89. First of all, males and females might differ in their, for instance, in their pain thresholds. And second of all, with age, we become less sensitive, for instance, to thermal stimuli. Another thing that we need to remember is that normative data is very much paradigm specific. For instance, if we use a rate of 1 degree per second, and then we use a rate of 5 degrees per second, you can imagine that in a reaction time inclusive test, the test results will be very much different. Another thing that we need to remember is the device type. We need to keep in mind that the same core technology is used and the same probe site is used. In this case, you can see that there is a probe, a thermo, we call that in Medoc, that's 16 by 16 millimeters. And there's one that is 30 by 30 millimeters. And of course, you can imagine that the 30 by 30 millimeters has much more spatial summation and therefore will have different results maybe than the one that is 16 by 16. The body side, we need to also keep in mind as there is a difference in innervation density and distance to the brain for different body sites. The three sources of normative data that are included in Medoc's software are the default normative data by David Janitsky that have warm detection and cold detection thresholds, both in the limits and the levels test for males and females between the ages of 20 to 79. Then there is Hafner, who have warm detection and cold detection in the limits test for males and females between the ages of 20 to 70. And of course, then there is Blankenburg, a very, very nice study on pediatric thermal thresholds, where he has warm detection and cold detection thresholds for the limits test in boys and girls in the ages of 6 to 16. So our normative data, our devices have um, comparable technology. Both the TSA, the TSA2, the Q-Sense, and the Pathway have comparable technology in the comparable thermode size. I want to show you two thermodes. This is the one for the TSA2, and this is the one for the Q-Sense. They have the same 30 by 30 contact plate, and therefore their normative data and their results can be compared, of course, if you have the same paradigm. And there is a study that has been conducted by the DFNS in which they compared the Q-Sense to the TSA, and they found that these results are comparable and valid. Having talked about static QST, of course, we cannot deny the subject and the differences between static QST and dynamic QST. In dynamic QST, we're mostly looking at pain processing. And we use usually several stimuli or an elongated stimulus, and we see the reaction that reflects pain processing in higher parts of the nervous system. When we talk about pain processing, we need to talk about pain ratings. And we have different methods that we can use for pain ratings. For instance, we can use a verbal method. We can ask the patient, how much does it hurt from 0 to 100 or from 0 to 10, and the patient will rate it on the numerical rating scale. We can also use the pain ratings that are integrated in Medoc software and have these windows pop up at time points that are defined by the user. And then there is a very, very high-tech method that I very much like, which is the COVAS, Computerized Visual Analog Scale. And this allows you to do continuous pain ratings with a sample rate of 5 times per second, approximately. And this also allows you very advanced analysis of the pain ratings, for instance, area under the curve. One such example of dynamic QST is condition pain modulation. And condition pain modulation is a psychophysical experimental measure of endogenous pain inhibition in the descending pathway in humans. And this is the pain inhibits pain phenomenon. And condition pain modulation is believed to represent a human behavioral correlate of diffuse noxious inhibitory controls. How do we conduct condition pain modulation, CPM? Is we give a test stimulus that's individually tailored. So usually we either go for using the pain threshold, or we try to find a stimulus that's robust enough, for instance, 5 or 6 out of 10 VAS stimulus. And we want it, of course, to be standardized. So we give the test stimulus once or in one batch, and then we have another batch that is either in parallel or after the conditioning stimulus. And here's the conditioning stimulus. And we want the conditioning stimulus also to be robust enough or at a large body area. I see that most labs use 3 out of 10 VAS ratings or 2 out of 10 VAS ratings. We want it to be remote from the test stimulus, for instance, the contralateral hand, the contralateral leg. And we either want it to be in parallel, like you see over here in the picture, or actually before the second series of stimuli. A very classic example of QST from this trial in Canada was that they did QST with a test stimulus of a thermode and with a conditioning stimulus of a cold bath. And they did 5 test stimuli, started putting the hand in the cold bath, and then another 5 test stimuli. The efficiency of the CPM is measured by the delta in pain ratings between the standalone test stimulus and the test stimulus during or after the conditioning stimulus. This very nice trial of the Freem lab in Tel Aviv University here in Israel used CPM with 2 thermodes because they wanted to look at the ability to do CPM within the trigeminal and outside of the trigeminal area. They validated pain intensity for each thermode position, and they had two thermodes working at once, with two TSA, previous TSA model devices. I just want to show you how it looks like if you would use the new TSA, which has two thermodes. You can see over here, the pink line represents the first test stimulus, like you see over here on the right. So I actually copied their protocol and put it in our software. In a few seconds, the orange line will come up, and this is the conditioning stimulus. The advantage of using a two-thermode CPM using TSA2 is that you can very well time your conditioning and the test stimulus, and you can put it almost anywhere on the body. Of course, you cannot put somebody's head in a cold bath, so that's one of the advantages. And you can see that we integrated the pain ratings in the software. Okay, so this is the TSA2 that I talked about. You can strap two thermodes to it, and then you can work in parallel. Temporal summation, on the other hand, is an experimental protocol demonstrating pain facilitation through obtaining pain reports along a series of identical stimuli. The common response is an increase in pain ratings along the series, and this represents the physiological phenomenon of wind-up. So you can see over here a model of a barrage of noxious input coming from this first order neuron to the synapse with a second order neuron. And you can see a decrease in depolarization threshold and an increased firing from the second order neuron. There are actually two types of temporal summation. There is phasic temporal summation, and in which we have a repetitive fast stimulus. It should be at least 0.33 hertz, according to Stout. Or you can have a tonic temporal summation, in which we have a continuous stimulus that keeps on going. I want to show you this example from the king of phasic temporal summation, which is Roald Stout. And he compared temporal summation in healthy controls with fibromyalgia patients. And he is always also looking at the after pain. So after temporal summation, several seconds on, looking at the pain reaction and the lingering pain in these patients. And he saw that in higher temperature ranges, there is a significant difference between healthy controls and fibromyalgia patients. I copied his protocol into our software, and you can see the speed with which the temperature goes up and down. The thermode he used for this was the pathway CHEPS thermode, and of course now we have the TSA2 CHEPS thermode, which is able to do the same speed, which allows you to do phasic temporal summation. I'll just let it run. You can see that I had the pain ratings pop up. You can choose to rate at the first stimulus and the last, or the first and the fifth. It's up to you. Okay. A nice example of a tonic temporal summation is by the Balgrist University in Switzerland, where they used a tonic stimulus using the search protocol. And when you give the search protocol, actually the person who is in charge of the stimulus intensity is the patient themselves. They are holding the response unit, and they can click a left side, and then the temperature will go up by 0.1 degree. And then they can click the right-hand side, and the temperature will go down by 0.1 degree. And this way, they wanted to look at tonic temporal summation in a type of an inverted pain rating. So they don't ask the patient to rate their pain, they ask the patient to stay at the same pain intensity. I just want to show you how this works technically. The temperature goes up to 45 degrees. And now we say to the patient, oh, okay, I want you to keep the same intensity. And the patient can press no, 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 no. And the temperature will go down. And they can press yes, 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 yes. And the temperature will go up. On the right-hand side on the graph, you can see that the patient actually had the temperature rise, which attests to adaptation. At the end of the stimulus, the patient had the temperature drop, which attests to temporal summation. And I find this a very interesting way to look at temporal summation. So temporal summation, to recap, can be conducted in a tonic and phasic way. You can use all types of thermal for tonic temporal summation, for instance, the 30 by 30 thermal that you see here, but also the Chepster mode. But in order to conduct phasic temporal summation, you either want to use the Chepster mode that can go up and down very, very fast, or you want to use the 30 by 30 thermal mode and increase the baseline temperature. Last but not least, I want to talk about offset analgesia, which is a form of endogenous analgesia characterized by a disproportionately large reduction in pain perception after a small decrease in a temperature during a noxious thermal stimulation. And in this case, I want to present to you this nice study from the De Haan lab in Leiden, the Netherlands, where they looked at neuropathic pain patients and healthy controls, and they did the offset analgesia protocol. In this protocol, the temperature goes up to, for instance, 45 degrees, stays there for 5 seconds, goes up to 46 degrees, stays there for another 5 seconds, and then goes back down to 45 degrees where they have been already and stays there for about 20 seconds. I just want to show you how it looks like in our software. And in this case, I used the COVAS here, the blue line, on the left-hand graph, and you can see that the ratings are going up. But then when we go back down to 45 degrees, they drop significantly. And this is also something that Niesters in her article found, that the temperature went up. You can see the blue line, that's the healthy controls. When it went up for another degree, the ratings went up again, but when it went back down to 45 degrees, the ratings dropped significantly, almost to nil pain. However, in neuropathic pain patients, you can see a big difference between the health controls and neuropathic pain patients in red. So all kinds of paradigms can be done with Medoc devices, and it's really based on what type of paradigm, what type of body site, and what type of research hypothesis you have, which type of technology you would like to use. And we have the QSense that is very, very well suited for static QST, but also for tonic temporal summation. But then we have also the CHEPS that can do it all, and the TSA2 that is that many thermals can be applied to. Well, then we got the results. So what do we understand from the things that we tested? First of all, we may want to compare our results to others. That may be normative data that has been collected by other researchers, or that may be normative data that you in your trial collect. For instance, from this trial in the University of Illinois in Chicago, where they had sickle cell patients compared to African American age and gender match controls. In this study, from the Keelung Changung Memorial Hospital in Keelung, Taiwan, where they use QST very much on a regular basis in their diabetic clinics. They compared diabetic patients to a normative data, and they saw that the more deficit can be found in thermal QST, and the more widespread the deficit is found, so let's say both in the hands and the legs, this attests very much to diabetic kidney disease and also to the severity of diabetic kidney disease. On the other hand, we can also compare it to other body sites, for instance, to the contralateral side. And I want to present to you a real test, a real case of a woman that is 52 years old, and she had a heavy object fall on her face 7 years ago. And since then, she had paresthesias and burning pain on the left side of her face. And this is a real case that I received from one of our users. And he tested bilaterally both cold detection and warm detection thresholds on both sides of the face. And you can see the huge delta in both cold detection and warm detection thresholds on the left side as compared to the right side of the face. This nice study from the Linköping University in Sweden looked at women with persistent pelvic pain and compared them to healthy controls within that same study. And they did QST both on the abdomen, on the lower back, and on the lower leg. And they found that thermal QST, both warm heat pain thresholds and cold pain thresholds, as well as pressure pain thresholds, were significantly different from healthy controls. The interesting thing is that they found this difference also in the lower leg, attesting to central sensitization. We can, of course, also compare our before and after an intervention, like this study from, again, from Niesters in Leiden, the Netherlands, where they had an intervention of giving tapentadol or placebo to diabetic neuropathy patients, and measuring before and after 4 weeks of intervention. And what they found was that CPM was significantly activated by tapentadol, and this also coincided with significant analgesic responses. In this study by the Janitsky lab into chronic post-thoracotomy pain, they found that CPM efficiency and acute postoperative pain intensity were two independent predictors for chronic postoperative pain. Pain thresholds and suprathreshold pain magnitudes did not predict this type of pain. And CPM also did not predict acute postoperative pain. Now that we have come to these conclusions, I would like to ask you, another poll. Oh, excuse me, the wrong poll. Which test would you like to use in your study, or which test do you find interesting? I'll give you a few seconds time to vote. I think I stop in a few seconds. Let's see if somebody else wants to vote. Okay, let me see if I can share the results. Well, your results very much attest to what we see in the literature as well. CPM is becoming very, very popular, and we can see that more and more labs are interested in implementing CPM in their studies. I want to conclude that QC comes in several modalities. We have static versus dynamic QC, and each has their own objective of what we're trying to understand. And QC can serve various purposes depending very much on your research question. And talking of questions, we love questions. I personally love questions. And I think we can go into the Q&A. And if we don't get to all the questions, I would really want to invite you to use my email and write to me, as I will be very happy to consult and think and advise, as we have a very big database of literature and knowledge. Let me see if there are any open questions in the Q&A. Not thus far, but there is a chat. Oh, okay. Okay. Any questions that anybody would want to ask right now? You can use the Q&A that's on the top of your window there. Okay. Mario is asking, what are the possibilities to use CPM in a clinical setting? And which questions can be answered by CPM? This is a very interesting question, and many clinicians are speaking about this. Many clinicians are considering this. CPM is a harder protocol, of course, to implement than static UST, as first of all, it takes some training, both of the user as well as the patient. The patient needs to be very much aware of what's the what the intention is. Okay, what and how they should rate pain. Rating pain is not very easy. uh, you can see people rating pain may be very high or very low, and you need to communicate very well what 0 is, what 100 is, what 50 is, for instance. And it takes quite a lot of time since you're combining several stimuli. However, CPM may give you some information on this person's pain processing. Something that I didn't mention in my presentation is that unfortunately we don't have normative data for CPM, and this is due to a few factors. One factor is the fact that almost any lab in the world does CPM differently. One lab chooses to use a pressure cuff, another lab chooses to use a cold bath, another lab chooses to use thermal stimulation, another lab chooses to use one fry. So there are many labs, and that's why we don't really get to collecting normative data. Another issue is that CPM there is very much variance in CPM also within normal people. There is some overlap between chronic pain patients and healthy people in CPM. And as you can use normative data for static UC, you can very easily say, oh, well, a very huge deficit in cold detection threshold. We should think, considering this patient is a diabetic, we should think of diabetic neuropathy. You cannot say the same about CPM. CPM on a group level, you may see differences between healthy people and, for instance, chronic pain patients, but on a personal level, it's very hard to match these results. However, something that should be kept in mind is that there are works about tapentadol, for instance, in this case, or duloxetine in one of Janitsky's studies that point that to a specific CPM profile of a patient that may or may not enjoy the use of a certain pharmaceutical intervention. And I'm very much hoping that there will be a big effort in trying to collect normative data and trying to understand a better personalized pharmaceutical protocol for chronic pain patients. I know this is not an ideal answer, but this is to the avant-garde or the best of my knowledge on this subject in the current state of affairs. And Tantra, you asked a very important question, and what the standard protocol for conditioned pain modulation. I know that there are some labs that are trying to gather their heads and come to a standard protocol. For instance, the Janitsky lab, I think they had quite a big study in which they also involved labs around the world, and where they did, I think, CPM with a cold bath, a thermal stimulus, and facial algometry. I can try and find that study for you, but as I said, there is no standard protocol. Every lab can choose what suits them best. And also, this is very much culturally bound, and also very much maybe based on your institution. I visited a customer a few years back in the United States where they weren't allowed to have the patient put their hand in the bath when the bath was connected to the electricity, and that they had to drag the bath over to another room in order to have the patient put their hand in the bath. So the choice of stimuli may be very much dependent on a specific lab's barriers or opportunities. Um, Offset analgesia, I know that there are, Chandra has asked, what's the clinical significance of offset analgesia? So offset analgesia also says something about our ability to have endogenous analgesia. There are also still a lot of questions about offset analgesia. Offset analgesia is quite less popular than CPM. I know of the Dahan lab. I think they use it also in a clinical settings, and maybe that's the subject of the next webinar. So this is something that needs to be commented upon by the users, I think. Sarah is saying that all of our normative data candidates are reaching 0 degrees on cold paint thresholds on limits. So the machine stops itself. That's true. Um, so why is the machine cutting out before normal candidates reach the threshold? First of all, um, first of all, I find it very hard to comment upon it because I think there need to be a a very strong definition of cold pain threshold. It may be dependent also on the body side, but you may see sometimes that patients will press very, very late for the cold pain threshold. They may press when they find it intolerable, while it started prickling a long while ago. So this is something that needs to be considered. Also, another thing that needs to be considered is that you have good contact with the thermode. Another thing that needs to be considered is the rate with which you are trying to reach cold pain thresholds. In the literature, I think the average is not 0. So you may want to research um, what makes people press 0 and what the sensation is that they feel when they reach that 0, because they say, oh, it hurts but I can still tolerate it. Then that's not their cold pain threshold. Their cold pain threshold is as soon as the cold has become prickly or or um, uh, uh, uncomfortable. That's their cold pain threshold. So this is something that you may want to consider. uh, I would be very happy uh, to have a one-on-one talk with you about this if you would like. Yara is asking if there is a possibility to conduct thermal temporal summation in TSA2 with the pulses method. Yes, of course. I see that most users that use temporal summation and they want to do Phasic temporal summation, they use it with the ramp and hold, so they can have just a little bit, like half a second pause at the top. So there will be so it will not be only just a small pricking feeling, but also actually reaching pain. Um, you can use the Chef's thermode, as I said, that can go down very, very fast. But I've seen also in literature people doing phasic temporal summation with the normal 30 by 30 thermode by raising the baseline temperatures by starting from, for instance, 40 degrees and not from 32 degrees. And then you don't need very, very fast rates in order to get to a super threshold pain. An anonymous attendee is saying that the talk is interesting. Thank you very much. And the recording will be sent. I'm not sure how. I will have to consult with people that understand Zoom better than myself. But we will send the recording. And if something goes wrong, please reach out to me. I'll be very happy to send it personally. A normal thermode, Yara, is a 30 by 30 thermode like the one that you see over here. So, sorry, uh, I'm too much in the business to think in a better way. But the normal thermode is the 30 by 30 thermode, and the chef thermode is a specific thermode that has a very strong technical abilities to go up and down very, very fast. Tantra will be grateful to have uh, uh, get the abstracts. I can send you also the full text so you can read a little bit. Um, I'll look you up and I'll send you the full text of the articles that I used in this study. Another entity is asking whether it's possible to use the TSA II for CPM. Of course, you can use it, depending on what your protocol is. If you only want to use the TSA for instance, the test pain, of course, you can do that. If you want to use it for the test plus conditioning, you may want to have two TSAs or upgrade to the new TSA2. But TSA 1.1, the Roman TSA, has classically been used also for CPM, and I'll be very happy to share articles that have used the TSA for conducting CPM, usually for test pain. But as you saw in the Levy article that I presented from the DeFreem lab here in Israel, they used actually two TSAs to have both test stimulus and the conditioning stimulus with a thermode. Are there any other questions that I missed? Would anybody else like to ask anything before I log off? Thank you very, very much for sticking around. I hope you enjoyed it, and we'll send you the recording of the session. And thank you. Thanks again. Have a great rest of the day.